Thank you for joining me today. We're going to be talking about disorders of the nervous system, and we're going to talk about the central nervous system, and then we're going to go into increased intracranial pressure, talk about vascular disorders like strokes, then we're going to talk about trauma, and then we already talked a little bit in the last video about spinal cord issues like spina bifida and anencephaly, so I don't think we'll cover that in this video. So let's start out talking about the cells of the central nervous system. And of course, you know that some of these cells are neurons, and the whole job of neurons are to transmit those neurological or electrical impulses from one place to another in the body. And the job of the neuron is to make sure that those impulses transmit as quickly as possible. Then we also have what are called neuroglial cells. And in the central nervous system, we have more neuroglial cells than any other type of cell. And these neuroglial cells would include astrocytes, which help to maintain synapses, and then they are also helping to form the blood-brain barrier. Oligodendrocytes produce myelin to cover those neurons so that the speed of transmission is very fast. And then we have microglial cells, which are phagocytes, and so they go around looking for any type of intruders to destroy them. And then ependymal cells. These ependymal cells line ventricles, and their job is to use the cilia on the ependymal cells to move the cerebrospinal fluid around. So just a few microscope slides, and you can see these are neurons, and in some of them you can see the neuron here and even the axon that's coming off. Here's another one with an axon, another one here with an axon, and then here's an astrocyte and an oligodendrocyte, and then microglial cells. And keep in mind what those microglial cells look like, because I'm going to show you a couple other slides where the microglial cells come in as phagocytes to clean up some debris. Then we have ependymal cells, and these are the guys here lining the ventricles. And then I love this picture. This is an electron micrograph of the ependymal cell, but in particular it's showing the cilia that's on these ependymal cells. Kind of cool looking. All right, so reactions of cells to injuries. So when a neuron is injured and it starts to degenerate, it becomes more of a reddish type of color. Astrocytes, they undergo hypertrophy and hyperplasia. Microglial cells, now because there's injury, they're going to proliferate, and what they do is not only do they get rid of intruders, but if there's any damage to neurons and other tissues in the central nervous system, their job is to help to get rid of that damaged tissue. And then we have oligodendrocytes and ependymal cells, and they don't really react much to injuries that are happening in the CNS. So this is a picture of a neuron that has been injured. Here's the axon coming off here. This is the nucleus of the neuron here. And one of the things that happens is the neuron swells up and you have chromatolysis of this neuron. And now you also have what we call dissolution of the Nissl bodies. Now the Nissl bodies is just another term for the endoplasmic reticulum, and what you'll see here is those Nissl bodies get kind of pushed to the side, and that's what these dark discolorations are. And then also because of the swelling, the nucleus also gets pushed up to the membrane, so it becomes what we call eccentric. Normally the nucleus would sit right in the middle of the cell body here. So the atrophy is occurring, and that is due to a loss of neurons in the brain. And what happens is when the atrophy occurs, as far as the brain or even the spinal cord is concerned, you can see a reduction in the size or the weight of the brain, and in particular maybe even in a specific area of the brain. So then we have neuronophagia. And this is that injuries kill neurons and create cellular debris. And remember, I told you, keep in mind what those microglial cells look like. Well, now you can not really see a neuron in here, right? I mean, it doesn't look like the pictures we looked at before, but see these little black things here? Those are microglial cells coming in, trying to get rid of that cellular debris. So we have that phagocytosis going on, and then you can even have leukocytes that come in, and they're going to accumulate because you have all this necrosis of the neurons occurring in some disease states like poliomyelitis. With poliomyelitis, this is a very contagious disease. It's caused by the polio virus, which is an enterovirus, and that means that the virus invades the body through the intestines. It mostly affects children about 5 years of age and under, and it spreads by fecal-oral transmission. Now, unfortunately, what that means is feces gets onto food or into water, and then you get this. In the good old days when polio was a little more rampant, one of the things that people would say is during the summertime the polio virus would spread more, and they would tell people stay out of the water because polio is transmitted in the water. And after a while people said, oh, well, that's ridiculous, that can't be true. But we do now know it is true, because now imagine you have a whole bunch of kids swimming in this body of water, and they have an accident, and now there's fecal matter in the water and people are splashing around. You get that in your mouth, and obviously contamination can occur and you can get this virus. So the polio virus, what it does is once it gets into the body, it invades skeletal muscles. And from the skeletal muscle, it's going to move to the motor neuron that innervates that skeletal muscle. And then it does what we call retrograde movement. And that means it moves back up that neuron. So it goes through the axon, through the cell body, and then out of the neuron, and it jumps into the spinal cord into the anterior horn. And if you watch the last video that we did on motor units and the diseases that happen there, we talked about the anterior horn and its control. And now, because this virus is in that spinal cord region, what happens is macrophage and other immune cells, leukocytes, they get into that spinal cord and they cause inflammation. And that inflammation leads to death of the motor neuron. Now, how that happens is the motor neuron isn't signaled any longer from the spinal cord, and that motor neuron isn't able to function. And now if the motor neuron doesn't function, it doesn't send signals to the muscle, and then we have muscle atrophy going on. Now, there's a couple types of things you need to know about polio. One is there's also a type called bulbar polio, and instead of going into the anterior horn of the spinal cord, this type of polio is where the virus invades the brain stem. And now once it gets into the brain stem, it's going to cause problems with speaking and swallowing, because of course this is part of what the brain stem does. And so now the motor neurons go into the diaphragm, can be damaged, and you have impaired breathing. And this is why some of the patients who had polio had to be put on what we would call the iron lung. Now, one of the other things that can happen is a person can have what's called post-polio syndrome. Now, this can happen decades after their initial exposure. So this person could be exposed to polio virus gets into their body, but they don't even know that they have it for a long time afterwards. And so originally, some of the motor neurons are going to have problems. They're going to be destroyed, and muscle cells are going to die. However, in order to prevent too many muscle cells from dying, what happens is other motor neurons are going to form collaterals. So usually you have a motor neuron stimulating a muscle cell, and this motor neuron now can start stimulating multiple muscle cells and allow those muscle cells to contract. However, as anybody ages, motor neurons die. And so now you may have this one motor neuron that has multiple collaterals and it's stimulating multiple muscle cells. And because a person ages, that one motor neuron dies. And instead of it only causing problems with one muscle cell, now it causes problems with multiple muscle cells. And now you have this extensive loss of muscle function. So about 95% of patients who contract this polio virus never have any symptoms, but 1% can develop what we call the paralytic poliomyelitis. So what we were just talking about those motor neurons dying off, that can cause this type of polio problems. And in the paralytic poliomyelitis, person develops high fevers, intense muscle pain, they lose muscle reflexes, and then eventually it can lead to partial or even full paralysis. Now, this paralysis is asymmetrical, which means it could just happen on one side of a person's body. It doesn't have to happen on both. And mainly it's going to affect larger proximal muscles, especially the muscles of the legs. And so if you look at any of the pictures of polio, like in the 1940s, 1950s, you see people in children, especially in these braces to help them walk. I knew a gentleman who lived in my neighborhood when I was younger, and he had contracted polio. And even though he was older, in his 50s at the time, he had to wear a brace on one of his legs to be able to walk. So it can be anything from bracing the person up to full paralysis. Unfortunately, there is no treatment for polio. You just have to treat the person for whatever they're dealing with, if they have infection or needing to put a brace on for walking, whatever it may be. Now, there is a polio vaccine. The polio vaccine that was originally used was a live vaccine. And one of the big issues with that vaccine was that when children were given that vaccine, especially if the children were very small and parents changed their poopy diaper, the parent didn't realize that the virus was being shed in that fecal matter. And so you had the person changing the diaper now contracting that virus. We now use an attenuated virus for polio, and it is very rare, although it can happen, it is very rare that a person would contract polio from this attenuated virus vaccine. So let's watch a video on polio.
Polio is a contagious disease caused by a virus that mainly targets children. Before people knew the importance of sanitation, babies often contracted polio at a young age when their mother's immune system still protected them, so the disease passed with no symptoms and the babies would not get polio again. As the importance of sanitation was recognized, children were not exposed to the polio virus until protection from their mother's immune system had long worn off. As a result, older kids became infected with polio and many experienced symptoms before the disease passed, 10 to 15% of them becoming paralyzed or killed when the virus attacked the nerves of the spine and brain. In the summer of 1916, the first outbreak of polio struck America. At the time, no one knew how people were getting polio, and there was no cure. Efforts to stop the spread of the disease were futile. Every summer, polio would hit again. Compared to other epidemics, polio did not kill many people, but it left innocent children crippled and unable to live a normal life. To many, this was worse than death. to fight polio, the March of Dimes was formed. This group asked for small donations to help pay for treatment for polio patients and fund research on polio. Thanks to the funds, in 1955, Jonas Salk created the first polio vaccine, and in 1961, Albert Sabin created an improved version of it, ending the polio epidemic. Miss Anne Duffy was born in the later half of the polio epidemic, which lasted from 1916 to 1955. She remembered what it was like to be a child during the epidemic. She also entered nurses training during the polio epidemic and treated polio patients. When Miss Duffy was a child, polio was thought to be spread in dark, crowded rooms. As a result, Miss Duffy and her brother were not allowed to go to the movies because the movie theater was dark and had a lot of people. In 1953, when she entered nurses training, the polio wards in the hospital she worked in were overflowing, and many patients had to stay in gurneys in the hallway. Some of the nurses in the hospital refused to care for the polio patients for fear of catching polio too, leaving student nurses like her who were not scared of catching polio to do the work. As part of treatment, to remobilize limbs immobilized by polio, nurses would wrap the limbs in hot rags and move the limbs back and forth. Many patients were also put in machines that helped them breathe. These machines were called iron lungs. Miss Duffy felt incredibly sorry for the patients that were confined in the iron lungs because they were only let out to eat and they had to stay in the iron lungs the rest of the time. When polio paralyzed a limb, the patient would always be dependent on someone else. Jobs were limited, and even cars had to be made a special way for them. Instead of killing, polio changed people in a way that made life harder, and that was what people feared about it. When a vaccine for polio finally came out, she, as well as the rest of the nation, was overjoyed and relieved that they no longer had to live in fear of getting polio. With the polio vaccine, people were made immune to the polio virus, ending the polio epidemic.
All right, so let's talk about astrocytes now. Astrocytes can go through what's called astrogliosis, and this is where the astrocytes will multiply in localized areas of tissue injury. And so, for instance, we see this happening in like Alzheimer's disease. And the question is the astrocyte creating issues, or are the astrocytes there to help take care of these issues? So this increase can be seen also in things like trauma and stroke and ischemia, or even autoimmune responses. You have a lot of astrocytes in that region, and we're not really sure exactly what those astrocytes are doing for us. Then there is also oligodendroglioma, which is where the oligodendrocytes have become neoplastic. So this is a cancer, and that neoplastic transformation is where we go from normal growth patterns to malignant growth patterns. And the problem here is demyelination occurring. And so here in this picture, you can see where a tumor has occurred, and these different regions here shows this oligodendroglioma. And one of the things that's interesting about oligodendroglioma is it's actually a very slow spreading type of cancer, probably one of the slowest spreading types. But it can create a lot of different issues, because this oligodendroglioma is like a little octopus, and it moves little tentacles of cancer throughout the system, and it can create, obviously you can see all kinds of issues within the brain, and eventually hit the brain stem and cause death of the patient. All right, so let's talk now about increased intracranial pressure. And this is typically due to edema, and this edema can be generalized, and that is, it can be from hypoxia or toxins, encephalitis, or even trauma. And then you have cerebral edema that is from like what we call a focal lesion, and that means you have something like a blow to the head, what we'd call a contusion, or some kind of penetrating injury where something enters the cerebral spine, or excuse me, the central nervous system. So for instance, a bullet, that would be a real penetrating injury, and I'm going to show you pictures of that later. And then also lesions in the brain. So increased cerebral spinal fluid volume is what we would call hydrocephalus. And then you can also have this intracranial pressure due to some kind of mass that's growing in the brain as well. So we have the edema, and then we have increased cerebral spinal fluid volume, and then we have some type of mass, all leading to increased intracranial pressure. So let's talk about hydrocephalus first, and we said this is an accumulation of cerebral spinal fluid creating a high pressure in the ventricular system. And this is usually due to impaired flow or impaired resorption of the cerebral spinal fluid, which we're going to talk about how this all occurs in detail. It's not typically because of overproduction of the CSF though. So if this occurs in infancy, and I'll show you also the infant's head may enlarge, and that's because remember, when these babies are born, they don't have fusion of all of the bones of the skull. Those joints have not occurred yet, so that that little head can get down the birth canal and the brain can continue to grow. So if after infancy, then what we see is the ventricles expand and you have that intracranial pressure increasing. So we're going to talk about circulation of the cerebral spinal fluid, and looking at this, you can see here is the lateral ventricle, and that leads into the third ventricle, which then leads into the fourth ventricle, and this fluid flows around the brain and around the spinal cord. And see these little things right here? And there's multiple of these in our brain. These are called the arachnoid villi. So once the cerebrospinal fluid is made in the ventricles, it's going to flow out around the brain through the arachnoid villi and then into a region where it's absorbed away from the brain. So in this picture, you can see here's the lateral ventricle, third ventricle, fourth ventricle. And so from the lateral ventricle, you're going to go through the foramen of Monroe into the third ventricle. From the third ventricle, you're going to go through the foramen of Magendie. And then from the fourth ventricle, you're going to move out around the brain through the foramen of Luschka, and then into the subarachnoid space, and then through the arachnoid villi and out. So normal intracranial pressure is anywhere between 5 to 15 millimeters of mercury, but if the pressure increases above 20 millimeters of mercury, the patient's going to require treatment. So signs and symptoms of this increased pressure would be slowing of mental capacity, headaches, neck pain, vomiting, blurred vision, drowsiness, even limb spasticity and difficulty walking. And of course, all of this is occurring because it's pushing on the brain and creating inappropriate impulses between one area of the brain and another. So you can see that you have all of this pressure from the ventricles and then even some pressure pushing inward. Most of it is the fluid pushing outward on the brain, however. So types of hydrocephalus, you have one that's normal pressure hydrocephalus. This usually occurs in the elderly. Then we have communicating hydrocephalus, and we're going to go through each of these. And the block is in the subarachnoid space. And of course, let's go back to this picture just real quick here. That's going to be this space right underneath here. And then you have non-communicating. Oh, by the way, in communicating, and I'll show you some pictures of this, the entire ventricular system, lateral, third, fourth ventricles are enlarged. In non-communicating, the block is in the ventricular system and only a portion of the ventricles are going to be enlarged. And this is the most common type. And then, of course, we have congenital, which this is fetal or infant hydrocephalus. And then this can all lead to something called ex vacuo, where the ventricular system is dilated, and this is due to brain atrophy. And then because of that, you make extra cerebrospinal fluid. So with normal pressure, remember I told you this occurs in the elderly. It's pretty rare. They have enlarged ventricles, but the pressure is normal. And the symptoms, one of them is gait apraxia, and this is difficulty not in walking itself, but actually getting up and initiating the actual walking movements. Once they get it going, they seem to be okay. However, dementia can be caused by this, and then incontinence. The cause is not actually known. Communicating hydrocephalus, there's normal flow between the ventricles and the subarachnoid space, but this is due to defective absorption of the cerebrospinal fluid. And so you get an accumulation in that subarachnoid space. Now the subarachnoid space is under the arachnoid. So this is going to be cerebrospinal fluid between the brain and the arachnoid. And the cause is typically from a couple of different things. One could be intracranial hemorrhage, meningitis, and even brain tumors. Then you could have a venous thrombosis, which means that the drainage is insufficient. Now this leads to atrophy of the brain tissue, and then what you see is all of the sulci are kind of crowding together. So you can see the ventricles very enlarged in these, and then you can see these pictures show all of the sulci crowding together. And another picture of communicating hydrocephalus where all of the ventricles are extremely enlarged. Non-communicating hydrocephalus, the reabsorption pathway is functioning fine, but cerebrospinal fluid flow is obstructed. And remember, we talked about the foramen of Luschka and Magendie, and so we have this region that is blocked. And this is usually due to some kind of lesion or mass occupying this region, or there can be some anatomy issues that have occurred. So this leads to enlargement of the ventricles. And so you can see in this picture, the arrow is pointing to a mass that causes this non-communicating hydrocephalus, and the ventricles obviously are very enlarged. Congenital hydrocephalus, we talked about, is going to develop in fetal stage or infancy stage and create dilation of ventricles, and the cause is usually an obstruction of the cerebral aqueduct. And then you can also have what's called a Chiari malformation. This is a condition where the brain tissue actually extends into the spinal canal, and this is present at birth. It's kind of interesting because not only humans get this, but some dogs can get a Chiari malformation. I had a really wonderful dog who, unfortunately, she eventually died from this malformation. And so you can see this. This is normal. See the cerebellum and where the brain stem is located coming into the spinal cord. And then you have the Chiari malformation, where notice how parts of the brain are pushing down into where the spinal cord should just be coming up. And this is causing pressure. It's also causing bending a little bit of the brain stem and creating pressure on the spinal cord. And that can create hydrocephalus, and it can even create death, of course. This a lot of time happens in premature birth, and because of the premature birth, the patient has bleeding into the brain, and then that causes this Chiari malformation or obstruction of the cerebral aqueduct. And then, of course, remember that their skull, is not fused, and so as their brain swells, their skull is going to get larger to accommodate that pressure. And then you can see very bad congenital hydrocephalus. This is hydrocephalus ex vacuo, and it just shows you how large these ventricles can become, but then also look at the brain atrophy that has occurred. And same thing here. So treatment of hydrocephalus is they use a shunt. Now there's two different shunts. One is called a ventriculoperitoneal shunt, and that's where they take the shunt and they put this in order to take the fluid out of the brain and move it into the abdomen. And this is probably the most likely treatment. Then there's also a ventricular atrial shunt where they're going to put in a shunt and move the fluid from the brain and then put this into the superior vena cava. So herniation of the brain is where one part of the brain gets pushed into another part. And symptoms, headache, vomiting, decreased level of consciousness, and even papilledema, which is swelling of the optic disc. And this can often be fatal. So you can see where parts of the brain have pushed outward, and this could be due to, like, for instance, a blood clot here, and that blood clot is creating pressure. Now, think about this just for a minute, because this is really important, and we'll talk about this when we get into trauma as well. Your brain is in a sealed vault, in a sealed container. So if there is pressure pushing on one side, it can then create pressure on the other side as well. So if I have a blood clot here and it's creating pressure on one side of the brain and causing this herniation, it can also cause pressure to move across the brain, and the other side of the brain can herniate as well. So let's look at a case of a football problem. You have a 17-year-old male who's knocked unconscious while playing in a football game one Friday night. A CT scan in the emergency room was normal. During the following week, he appeared normal but was secretly suffering from headaches. He played part of the game the following Friday before collapsing on the field. On exam, lethargic but awake, he had decreased vision in part of his visual field of the right eye, limited ocular motility, ptosis of his left eye, and this is what you see here. Here's the ptosis of his eye. He had impaired adduction of the left eye and somewhat limited elevation and depression of the left eye. Rushed to the ER again, where a CT scan showed a left subdural hematoma with a midline brain shift. So that means he has a blood clot on the left side, and this has shifted his brain. And that's what you see here. So here's the subdural hematoma, which is pushing his brain over. And of course, here's the herniation here into the brain stem, and that is creating all of those symptoms, which, by the way, most people will tell you that typically subdural hematomas aren't that big of a deal, but they are. And this can create a lot of pressure, and that herniation, of course, could potentially lead to death.